We had a Swedish professor who was at that time in his 80s. And he was asked a question that, Dr. Strom, when do you think a person should stop exercising? Or when is it too late to start exercising? So his answer was that if you are under the age of 100 and you are alive, you should be exercising. So the message is never too late. It's never too late.
Here's something to think about. Why does a small fall mean nothing to children? But the same fall can change the life of someone in their 60s. That's the story of our bones and joints. They carry us through life. But if we don't look after them, they can let us down when we need them most. Welcome to Brighter 100, the podcast where we explore the science and stories shaping the future of health and well being. Today, we are joined by Dr. Hemant Kalyan, one of Bangalore's most renowned orthopedic surgeons and sports medicine specialists. Dr. Kalyan is a gold medalist in orthopedics, the first Indian to earn a Royal College's diploma in sports medicine, and a pioneer who brought advanced arthroscopy and robotic joint replacement to India. Over 3 decades, he's treated elite athletes, weekend warriors, and everyday people who just want to move without pain. In this episode, we will talk about what really keeps bones and muscles strong, the myths around bone health, how to prevent common injuries, and why looking after your joints isn't just about avoiding pain. It's about living longer, healthier, and more independent years. Dr. Kalyan, welcome to the show.
Good morning.
It would be great if you could give us a short introduction about yourself.
Okay. So I'm a bone doctor or a human hardware engineer, if you like to put it that way. So essentially an orthopedic surgeon who, loves to restore mobility to people as a passion of my life. So I can say that it's a hobby for which I'm being paid for.
Great. We'll just start right at the beginning. Orthopedics, when you really look at the history of orthopedics, it's always had a bit of a quirky past, from the rudimentary bone setters to crude splints to x-rays, and then of course now arthroscopy and so on. What stands out to you as the most fascinating part of the earlier history?
Yeah. So I think it's relevant to start right from the meaning of the word itself. So way back in 1741, as early as that, there was a French physician called Nicolas Andre, who at that time, at a ripe old age of 83, and remember that longevity at that time was not like today, he wrote a book about educating children and their parents about correcting deformities and preventing deformities in children. So the word orthopedics actually has a ped component, which is children, and very literally and crudely translated, it means straightening the child, which referred to straightening children's deformities by simple things that the mother could do when the child was growing. So that really set the tone for early days orthopedics as we practice it today. And one of the famous illustrations in his book was that of a crooked tree being held up by props. And even today, that is used in many orthopedic associations and journals as their icon picture after 300 plus years, which is remarkable. And he made the point, that stage, saying that the bone is like a tree.
Right.
It's a living organism and is capable of growth and is capable of remodeling and repair. So I think that the real credit for understanding orthopedics the way it is and practice today really belongs to that era. So it's been a fascinating journey from then. And if you look at the pace of change of various things the world over, orthopedics has been following the same trajectory. So in the 1700s, 1800s, and it was a slow progress. And then surgery itself came of age after the invention of antiseptics and safe surgery, where you could do surgery by and large without infection or with minimum infection. And then came the antibiotic era, and then came the Second World War, which were the real landmarks in modern day orthopedics. Indian scenario, the bone setting has been a very, very ancient science. And with due regards, in certain respects, it still works, that the concept of splinting
Right.
is used by the village physicians, by the so-called indigenous physicians. They understood the concept of immobilization, that you have a fracture, you immobilize it, and over a period of time that can heal. So that's the difference between humans and wild animals. So if a wild animal had a fracture, that he or she would die because can't hunt anymore. They'll become prey for other animals. And fracture in a lion, for example, if a lion fractures a femur, it's a terminal event because the pride will abandon that lion and that lion will be devoured by other carnivores. Fracture.
When you first started practicing vis-a-vis now, what are some of the practices that have completely transitioned or even disappeared from what you started with?
I think, it's, I did my residency in orthopedics in the 1980s. 1985 to 1989 was the period of my residency. And then I did my fellowship and then I started practice in Bangalore in 1993, which is 32 years ago. It's been fortunate that I've lived through that period where the entire change uh, in orthopedics worldwide and in India has happened during that period. So, if I look back at my residency, just to give you an example, in the 4 years of my residency, my then boss, Dr. Dheer, did one hip replacement in 4 years. And today, I would do an average of about 5 or 6 knee and hip replacements in 1 week. So, that just gives you a very simple kind of. And I worked at an extremely busy hospital and we had, inundated with cases, but that was it. Now, if you look at fractures, for example, those days we used to put people into traction. Like if they have a hip fracture, we would put in a pin in their tibia bone and suspend it on traction for 4 weeks, 6 weeks. The patient would be in hospital for 6 weeks and try to prevent bed sores and lung infection and urine infection and the blah, blah, blah. At the end of 6 weeks, you slowly start walking. And, it is today, we'll do a hip fracture in a 95-year-old today, and tomorrow the patient will be out of bed. So it's been a sea change. Now, you're talking about arthroscopy, for example. I mean, those were the days, when the early days of arthroscopy, and I did my residency in Mumbai. We used to have these debates, that why arthroscopy? Why not do it regular surgery? And people would argue that why do you want to look through a keyhole when you can open the door? But the fact is that when you open the door, there are parts of the room which you can never access. With the keyhole, you can get into sections of the joint which were inaccessible
Right.
by open surgery. You need 3 different incisions to do the same surgery. So I can say that it has completely exploded the whole orthopedic scenario. And then, of course, with the liberalization of the Indian economy, which took place in the early 90s, that's when we really caught up with the rest of the world, and the lag between availability of technology in the West and its application in India became from decades to years and from years to months, and now it's months to weeks. And now we are in a situation where the Indian innovators of procedures and people from the West come to India to learn from Indian orthopedic surgeons. So we've seen the whole cycle change, and it's really been a fascinating journey. So I think I've my career has spanned that entire period of change. So I've been very fortunate in that regard to live through that.
So you were mentioning about your career over the last 3 decades. What sort of specialities did you bring in, and what was some of the elements that you have transitioned or changed completely in your medical practice?
Yes, absolutely. So, I mean, I've been a great fan of technology from a very young age, and I had a hard time choosing between engineering and medicine. And in fact, back in the day, I found that the reason I took orthopedics is because orthopedics really marries engineering and medicine, and it applies many engineering principles into medicine. And as I said in the beginning, I can say I'm a sort of a human hardware engineer, if you like to call it that. So the change that I was personally a big part of in Bangalore was the introduction of advanced arthroscopic systems in Bangalore. Because when I came to Bangalore, there were only 3 of us, 3 surgeons in Bangalore at that time who were practicing operative arthroscopic surgery.
Let's start with the fundamentals. What exactly is bone? Because most of us, when we think of bone, we think of it as a hard stick in the body. But what is it really made of? And how do you explain that bones are actually living, dynamic tissues?
Correct. So I think that's a great question because the perception of bone, as you rightly said, is it's a wooden stick in the body which supports the skeleton. But in fact, the bone has it's a living tissue which consists of a network of cells that is which are absolutely interlinked with each other. They form a sort of a matrix, and the matrix is mineralized by calcium and various other chemical compositions, and that has blood supply just like any other tissue has blood supply, and it has a protective covering which has also got nerve supply. So it is no less than a living tissue than anything else. Bone also gets renewed in the body. So what bone you have today, just like your blood cells get recycled, your bone also gets renewed. And even if you live up to the age of 100 years age, you'll still have a continuous process of bone resorption, which is the old bone being taken away and new bone formation, which happens throughout life. During the
That's the osteoclast and osteoblast, right?
Exactly. The osteoclast and the osteoblast. And the concept in the human body is homeostasis. Homeostasis is a state of equilibrium in which the formation and the resorption is perfectly balanced so that what's removed, it's what's replaced. And that is the ideal situation which would happen throughout young adult life, maybe into middle age. But obviously, with diseases and with age, that process undergoes certain modifications and changes. So that is one thing to remember, that bone is a living tissue. The other thing which I want to say right at the outset is the bone has response to something known as Wolff's law. Now, this Wolff's law is a simple thing to understand for anybody, that basically the bone will respond to the stresses applied to it. What stresses are applied to it? The stress, if you're walking, the weight bearing stress is your stress applied to it. If you are doing manual work, then the muscle strength and the resistance you get from the object you are lifting is a stress applied to it. If you are playing a sport, it's the impact of the ball on the racket, which is a stress applied to it. And the bone responds to that. So now, for example, if you take a professional tennis player and you see the right arm and the left arm, then it's very likely that the right arm, if he or she is a right handed player, will have greater bone strength, more of bone density in that particular area in the same individual in two parts of the body.
Wow.
Take the example of someone like Sunita Williams, spent 9 months in space without any ounce of weight bearing on her body. The big concern with her is osteoporosis for that period, even though she is not really in the osteoporotic age group, because when she returns to the planet Earth and starts normal activities, then there has been no stress on the bone for a good 9 months, which will require treatment. And that's part of an astronaut's rehabilitation, is to treat osteoporosis. So basically, the bone responds to physiological stress. And the important word, the catchword is like physiological stress. So when it is stress beyond the elastic limit of the bone or beyond the capacity to bear it, it'll break.
Would you say that it's literally like if you don't apply stress, it's your bone is literally leaching away? Would that be the appropriate
I
thing
think
to?
that's a simple way to say that. That essentially, if you don't apply stress to the bone, it's going to, it undergoes something known as disuse osteoporosis. Disuse osteoporosis. So it's something like, for example, let's say that someone has a fracture, right? And you put their arm in a cast for 6 weeks. At the end of 6 weeks, when you remove the cast because they have not used that hand normally for anything bearing weight, and you take a simple X-ray of that bone will look less dense than what it was to begin with, or compared to the other side. That's known as disuse osteoporosis.
That's a good point because most people also confuse bone with muscle and joints as if they were all the same thing. How do they differ and how do they work together?
Yeah. So if you see human locomotion and human, the way you and I do day-to-day activities, it is a complete integrated system, a beautiful system controlled by the central nervous system, starting from the brain and then the spinal cord, and then the nerves which emerge from the spinal cord, which are the peripheral nerves, and then that goes into the muscles, and then the muscles attached to the bone. And when I say I want to lift up my hand above my head, the signal starts from the brain. Then you have the nerve impulse, which activates the muscle. The muscle sends the signal for the movement, and then the bone will support the muscle while it does the action. And all that happens within a fraction of a millisecond, right? So it's not a conscious process that we have to put ourselves through. So the entire system is a nerve, muscle, bone, self regulatory loop, which keeps on perpetuating itself. So every step that you take, this entire cycle repeats itself again and again, like your heartbeat does. And, you know, that's how you walk. So the difference essentially is that the bone is a living tissue which is basically supportive and does not have any independent movement. But without it, you cannot have movement. The muscle is the contracting tissue which will actually produce the movement by an attachment to the bone through a elastic tissue called a tendon. So you have a muscle, a elastic part of the muscle which is called the tendon. Tendon attaches to the bone. Muscle requires nerve and blood supply like everything else does, and activation of the muscle will transmit the force to the tendon, tendon to bone, bone will support. And the joint is actually, you have two types of joints. One is the joint which actually causes movement, like say the elbow or the knee or the hip. Those are the joints which cause movements. And then there are supporting joints. Like, for example, in the pelvic bone, there are a lot of supporting joints, like they are joints in the back of your, next to the pelvic bone, tailbone, you have something called the sacroiliac joint, which is a very essential joint, which is a supporting joint. In itself, the movement in that is very, very minimum. It's only designed that when a woman gets pregnant, it'll expand so
Support.
that the baby's head can get into the pelvis and ultimately she can have a normal delivery. So that's a restricted movement function, but throughout life, it's mainly a supportive joint. So joints are by and large the ones which cause movement, but the supporting joints are exceptions like the sacroiliac joint.
Yeah. Now, men and women, are there any fundamental differences between men's and women's bones in terms of density, strength, and how they age?
Yeah. So I think the fundamental difference is basically in the structure of the pelvic bones, because woman's pelvis is designed for childbearing, whereas in males there's no such function. So the fundamental difference is in the size of the pelvis or the shape of the pelvis. Because of the difference in the pelvic structure, the angle at which the hip joint and the knee joint comes together, that is slightly different in males and in females. Generally speaking, in humans, males are bigger made than females. So in terms of the length of the bone and in terms of the structure of the bone, inherent structure of the male bone would be stronger, and the female bone is subject to hormonal changes. So in children, the male and female bones are almost similar. In fact, there'll be a phase when the girls' bones are stronger than the boys' bones. Then, of course, there'll be menarche, and at the age of 20, the girl would have her peak bone strength, bone density, as it were. And with menopause, but the main thing is because of the tailing off of the estrogen hormone levels. Estrogen having a protective effect on the bone as well as the heart. Of course, heart is not the subject of our conversation today, but being having a protective effect on the bone. As the woman attains menopause, there would be a tendency for bone loss at an accelerated rate for the first 7 years after menopause. So this is the time when, because of the estrogen getting depleted, there would be a sharp decline in the bone strength or bone density of a female post menopause. And after 7 years, it continues to decline, but at a slower rate. Right. So that is what is called as a senile phase of bone decline or senile osteoporosis, as opposed to the postmenopausal dip. So the first 7 years after menopause is the time when the bone strength in a woman would inherently decrease a lot. And that's actually, from a preventive point of view, that's the time to do intervention and prevention, ideally. And even before, maybe, yeah.
So, in all these years in your practice, what are some of the myths that you would like to bust as far as bone health is concerned?
One is this whole perception that nothing can be done about bone osteoporosis. That, once you have osteoporosis, then it's a one-way downhill street and nothing can be done about it. Or that if you take calcium and vitamin D, that's
Right.
good enough. So, and there's also a myth that too much calcium, how much calcium, shall I have calcium once a week? Shall I have it daily? Shall I have it alternate days? Will it cause calcification in my blood vessels? Will it cause kidney stones? All of that. So some of these are justifiable concerns and some of them are, hand-me-down myths as well. Maybe we could start with calcium. So calcium, remember, is basically a mineral supplement which can be obtained from diet and it can also be obtained from medication. Now, the factor that affects the absorption of calcium in the body is vitamin D. So, vitamin D, you could think of it as a gatekeeper. So, if the vitamin D is in the body is adequate, then you would open the gates for calcium to get absorbed from the diet into the bloodstream, and from the bloodstream it'll go to the bone where it can get mineralized. Now, what is often overlooked is that calcium is not necessary just for bone health, but calcium is also necessary for heart function. So, essentially, the body's instinct is to protect itself, to sustain life. So, if your vitamin D is low, then the absorption of calcium or the transfer of the calcium to the bone will be compromised because the body must maintain blood calcium levels to sustain heart function. So, the related myth is that, doctor, I have got normal calcium levels in my blood. Why do I need to take supplementary calcium? Why do I need to include calcium in my diet? My blood calcium level is normal. Simple logic will say yes, blood calcium level is normal. Same person, you take the vitamin D level, and the vitamin D level is deficient or insufficient. Now, in that case, I have to tell them what I just told you, that see, your blood calcium level is being maintained by the body to sustain heart function. But the calcium that will go into your bone will be compromised. So you're going to get a higher chance of osteoporosis. So essentially, calcium and vitamin D will go together, and it's as important to maintain adequate vitamin D levels as it is to maintain calcium levels. The second thing that many people are worried about is the risk of kidney stones. Now, kidney stones is a justifiable risk. There's no doubt about it that if you have a tendency to form kidney stones, then excessive calcium would contribute to that tendency. But it's not a simple equation here. So, if you have adequate water intake and if you take certain types of calcium which are more soluble, like you have different salts of calcium, like calcium citrate and calcium citrate malate, which are far better absorbed. So the amount of the efficiency of calcium absorption of these salts is much better. So if you have 60-70% absorption of calcium citrate versus say 30-40% absorption of calcium carbonate, it stands to reason that you need to take less calcium citrate to give you the same amount of calcium as you would by taking more quantity of calcium carbonate. Because if you look at the absorption, what goes to the body is the same. So the reason we use calcium carbonate as a default is because it is cheaper and easily available and affordable to everybody. The calcium citrate and now a little more expensive.
I think one of the other things which most people get reluctant and worry about is the atherosclerosis part, where people get worried about calcification of arteries. Maybe you can tell us a little bit about that.
Again, one thing we have to understand is that calcium gets deposited in the body in areas of degeneration, right? Now, for example, in the blood vessels, with age, you get hardening of the blood vessels. The musculature, the smooth muscles in the blood vessels become less contractile, less efficient in contracting. So they become more rigid structures rather than contractile structures. So they don't transmit the blood that efficiently. So harder blood vessels have a tendency to get calcified. So degeneration, say for example in the shoulder muscles, you have rotator cuff muscles which get degenerated after the age of 40, 45, and there can be calcium deposition in that muscle. So there, the calcium is not depositing because of the dietary calcium. That calcium is depositing because of a degenerative process, and in degenerated tissue in the body, you can get calcium deposition as part of that degenerative process itself. So, by and large, I would say that there would be certain specific situations where the cardiologist would advise that yes, you need to restrict your calcium intake, or the nephrologist might advise that you need only this much calcium per day because of the compromised renal function. But in a person with a reasonably normal cardiac and renal function, calcium intake orally is safe.
You mentioned degeneration. The degeneration is also because of poor bone health, or what would be some of the reasons for the degeneration?
Yes. So degeneration is a multifactorial thing. So one, of course, is the heredity factor. So there is no doubt that even degenerative diseases have a certain heredity predisposition. It's not like a simple genetic hand-me-down kind of thing. But if in case your immediate family had a degenerative history, the chances are that you can get it more chances. But there are all lots of other factors. Body weight is a great factor. So, for example, if you are overweight or obese, certainly that will accelerate degeneration. An injury to a certain area, for example. Let us say you've had an injury to the knee, and that knee ligament injury was neglected. You had that during as a college footballer. Now you're 45 years old. Nothing was done about it at that time. Then, because of the abnormal loading of the knee, surely you can get degeneration due to that. You can also get degeneration due to certain chemical factors, say, for example, some toxins, some infection, some inflammation. So, all there are multiple things which can lead to degeneration. Some of them which are preventable, and some of them which are modifiable to a certain extent.
So that's a good segue for us to get into the prevention aspect for a lifetime. What are some of the, or rather, why are the 20s and 30s the make or break decades for bone health and bone protection?
Yes, that is an excellent point. See, 20s and 30s is a carefree phase of one's life when one is concentrating on education and love life and setting up families and all of that. But health comes very low down on the list of priorities, unfortunately. See, if you look at, for example, a woman's body, her peak bone density is achieved by the age of around 20. What achieves that peak bone density? Besides the genetic factor, which you don't have influence over to a great extent, let us say that a particular female has been very active in her sports during those years, during her teenage years. Let's say she has been adequate with calcium and vitamin D. She's been doing weight bearing exercises. She's been doing, sensible workouts, which will, by Wolff's Law, encourage the bone strength. Then she's setting herself up for a great bone density to begin with. So you're starting off with a good bone balance, just like your bank balance. If you have a healthy bank balance, you got more money to invest in. So if you got a healthy bone balance, you got good bone to invest and spend. So that's where your starting is. Then comes the phase of the 20s and 30s. Now, if you look at the lifestyle of our 20s and 30s, say in a city like Bangalore, most 20s and 30s who are, say, employed in the IT sector, although there's an increasing fitness consciousness, large number of them would spend 8 to 10 hours in a closed office.
If someone is in their 20s and 30s and probably working in an IT or a desk job, what would be your advice to them?
I think that's a very relevant question given our Bangalore population. So essentially, person who is spending 10 to 12 hours at a desk and with hardly any exposure to sunlight, living in an ultraviolet controlled environment, and spending most of their recreational time on another screen, and with a weekend only to do some chores with occasional physical exercise, is basically setting up to squander the bone balance that they have to begin with. So, nature has given you your best bone balance at the age of 20 without doing anything. Even better if you do something. And then it's really up to you. Because if in case you use this opportunity to have an active lifestyle, regular physical exercise for about 5 to 6 days in a week, don't need to do anything extra special. Just moderate physical exercise for about 30 minutes a day, which we can go into if you like the details. Reasonable exposure to sunlight, making sure that your vitamin D is adequate. Don't even need supplementary calcium. Taking frequent mini breaks at work All these simple interventions can actually lead to a lot of prevention of a lot of issues for later life, can improve your work productivity while you're at work. And really, it's a win-win for everybody concerned. And this is especially more so for females because, as we know it, there is no specific male menopause that we are able to clearly identify, but there is clearly a female menopause that we know about.
Right.
So, building up bone strength and maintaining bone strength and muscle strength, equally important at this stage, is so very important to really prepare that when you land at menopause, you're already proactively preventing some of the issues that are bound to happen physiologically at that age. So I think it's a lifestyle choice that should be made for a more physically active lifestyle. So sitters move around, important.
What about somebody in their 40s or 50s and feels that, is it too late? What are some
No,
of the most effective steps that they
it's
can
never
still
too
take?
late. When I did my sports medicine in the UK, 1990s, early 90s, we had a Swedish professor who was in his at that time in his 80s, and he was asked a question that, Dr. Strom, when do you think a person should stop exercising, or when is it too late to start exercising? So his answer was that if you are under the age of 100 and you are alive, you should be exercising. So the message is never too late. It's never too late. If you've not done it in your 20s and 30s and you don't do it in your 40s and 50s, then you go into your 60s and 70s not having it done in your 20s, 30s, 40s, and 50s. So, in your 40s and 50s is a great time to start physical exercise. But you have to remember that there are certain physiological changes happening in the body from 40 plus. And the commonest mistake 40-year-olds make is that they last memory of exercise when they were 19 or 20, and they go back to that point and say, let me run 5 kilometers in the day one, and that is the start of all your bone and joint issues, which are completely preventable by just applying the right principles of training. So I think people should understand that as you progress in age, you need to respect your age. It doesn't mean that you restrict your activities, but you get to that point systematically, safely, and physiologically.
Essentially, what you're saying is, one needs to evaluate the risk before starting something very aggressive and possibly do a progression on a step by step basis
Yes,
versus trying to get to stage 10 from day one. Okay.
absolutely.
What and how do we measure bone and muscle health? What are some of the most important tests to check for bone and muscle as we age?
Right. So the easy one is the bone health. So in bone health, if you look at measurable parameters, the so-called gold standard that we use nowadays is the DEXA bone density test. So the DEXA bone density is an X-ray based test, and that basically gets data from a huge population which is specific to specific ethnic group and specific gender. Say for example, if we have to measure an Indian woman at the age of 50, her DEXA bone density, then her density should be compared with Indian population females, and then we do two comparisons. One comparison is with a 20-year-old female, which is the peak bone mass level, and the other comparison is with her own peer group, that is the same age group. So the bone density result, if you see, you will get two scores. One is called as a T score and one is called as a Z score. Now, T score measures your bone density relative to a 20-year-old. So, what should be ideal and where are you now? And the Z score measures your bone density relative to your own peer age group. By definition, if you get score of minus 2.5 or less T score, then that by definition is osteoporosis. You're between minus 1.5 to minus 2.5, you'll call it as osteopenia. And if you're under minus 1 to 0, then it will be considered as normal for your age. So, this is the WHO adopted criteria to measure bone strength. So, that is the one criteria. It has its own limitations, but it is a reasonably good criteria.
Especially in India, I
Yeah.
think one of the challenges which I see quite often is the fact that we don't have enough data and enough research. So how do you then evaluate, saying that you mentioned, I'm being benchmarked against a 40-year-old or a 50-year-old of my same age category, but how robust is this data and how robust is our, you
No,
know,
I
measurement?
think as far as bone density data is concerned, we are quite all right in terms of we have adequate amount of baseline to measure. So that's not really a big concern. It may be applicable in other areas, but as far as density is concerned, DEXA bone densities in India are reliable, and we've got enough for baseline population to benchmark against. So that should not be an issue.
Okay. So you mentioned DEXA. So what would be some of the other ways to measure?
So you have something known as a FRAX score, where you basically also have to look at the history. And for example, if someone has had a fracture of, say, the wrist, then his or her chances of getting a fracture of the other wrist or of the spine or of the hip exponentially increases. So with each fracture, the risk of another fracture exponentially increases. So that is something we have to take into account, is has the person had a fracture. So it's not just a linear correlation with bone density. Bone density may be relatively all right, but the patient has had one fracture. We have to treat it more aggressively. Are there secondary factors like hypothyroidism? Is the person on corticosteroid medication? Is she diabetic? Is she very asthenic built in the bone mass is way below what it should be for her age? All these factors, what's the activity level? All these factors will come into play when we advise treatments. The FRAX score combined with the bone density will be a more holistic kind of approach to bone strength assessment.
And when should somebody start getting bone density scans or strength assessments done? Is it only after 50 or 60, or is it
Yes.
earlier
So
than that?
if a person has got risk factors, let us say someone has had a very early menopause at the age of 35, then definitely I would suggest that you could get the bone density done earlier. If the person is taking thyroid medications for 15 years, then yes. If the person has had, history of steroid intake, anti-epileptic drugs, yes. But for a person who's been a reasonably healthy person, the good time to really assess it is part of the perimenopausal assessment. So when she starts getting into the menopausal age group, apart from the routine gynecological examination, screening for various types of malignancies of the female, uh, you know, reproductive system, you also should include bone density assessment at that time. I would recommend that it should be a routine test for urban population, at least uh, around the menopausal age group, once then as a baseline. Then it need not be repeated every year. It can be repeated every 3 to 5 years to track the progress. If you're on treatment, maybe you could repeat it every 2 to 4 years, but there is no need to repeat it every single year.
But what about men? You mentioned about women.
Men is a very interesting question, because now in men, there is no specific menopausal timeline which we can identify. Not really clear. So for men, generally speaking, people with risk factors, certainly we would advise bone density. Even if they've had a fracture, I would say yes, because then you need to see what's the level of osteoporosis they have. And any male above the age of 70, definitely, even if they've been very healthy throughout their life and no other comorbidities as they were, at the age of between 65 and 70, I think it's worth getting a baseline bone density and then follow the same pathway as females, because by 65, 70, the females and males will be kind of equalized. The males will be equally prone to senile osteoporosis as females are. That is what I would suggest. The other question you asked is about muscle strength. Muscle strength is far more difficult to assess objectively. So you can use simple tests like,
Grip strength, yeah, yeah.
grip strength. You can use, measure thigh girth. You can measure arm girth. This kind of thing. You can do the body composition analysis, the lean mass versus the fat mass.
And what about things like balance and posture?
Yes. So balance and posture and so on would be more of a clinical assessment or assessment, say, by a physical instructor or a trainer. the ability to stand on one leg, the ability to walk backwards, the ability to stand with one's eyes closed for a few seconds. How long can you do a plank? Things like that. Those are tests for balance which can be easily used. But those are, you don't have clear cut values that, numerical values that grip strength of so much. So it is a bit subjective, but these are useful parameters to measure. And until something very definitive comes along, I think we should do something rather than do nothing.
You mentioned estrogen a lot. Are there other hormones which play a critical aspect as well, like, for example, testosterone or growth factors?
Testosterone, is a hormone which is present in both males and females. And testosterone in males, of course, is at a much higher level than it is in females. So testosterone is very closely linked to the muscle mass. And essentially, if you are deficient in testosterone, then you're likely to get something called as sarcopenia. There are very other reasons why you get sarcopenia. So, testosterone assessment is also recommended in certain situations, but those would be done less commonly, especially people with certain risk factors. But we wouldn't do a routine testosterone assessment in males or females unless there is a real reason to do so.
One of the other big myths which I see floating around is, oh, walking is good enough for me to maintain my bone health and my muscle health. What would you tell them?
Absolutely. I think you've hit upon a perfect point. Long back, I had written an article saying that walking is not enough. So, walking, you see, essentially is a good cardiovascular exercise. There is no denying that. And it's an easy thing to do. It does not require any training. And, it's part social activity and part exercise activity, which anyone can do. And I'm not for a moment saying that walking is not a good thing. Walking is not enough. Apart from providing cardiovascular benefit, and being weight bearing for the lower limbs, it does almost nothing for the upper limbs. It has almost no role or very limited role in core stabilization. It has very little role in balance and coordination. So essentially, any good exercise program at any age should take into consideration cardiovascular aspect one, second is strength aspect two, and third is balance and coordination, and along with that flexibility. So all of these elements should be incorporated into your exercise program. So ideally speaking, if you're doing 6 days a week, you may do 2 days where you're mainly cardiovascular focused, 2 days where you're mainly strength focused. So you should do some resistance exercises, and we could get into how to go about that. Low weight, more repetitions for less risk. Because if you're doing resistance exercises to build muscle tone and to build muscle bulk, it has completely different kind of training requirements. Say, for example, you want to build muscle bulk, then obviously your priority is to, do more
Load.
weights, heavy loads, and then gradually build up the number of reps. If you want good muscle tone, you could do the same thing with lesser weights and more repetitions, safer for the muscles. You can do that. Strength building is very essential because going forwards, the risk of falls in the elderly is as much to do with poor strength and poor coordination, of course, with poor eyesight and hearing, as it is with do with weak bones. So we cannot divorce the two. They have to be in parallel: walking, bone strength development, and strength building. And I think strength building is underemphasized in our training programs
And in our culture,
and in our culture. Absolutely.
especially for women, I think that's been a, you know, most of the women are told, oh, you're a woman, you don't need to go to the gym, right?
Absolutely agree. And I'm glad that this is slowly changing. But yes, you're right that you should be very cognizant and from a very young age. So you can do it as you're building your bone bank in your 20s and 30s, build your muscle bank also in your 20s and 30s.
For some of the senior citizens, what would be the most effective and simplest forms of prevention strategies that you would recommend?
Yeah. So for senior citizens, you can do several simple things at home. You don't need to invest in huge gym equipment. You can use simple weights like 1 kg bag of rice or things like that at home. You could just at low cost get some 1 or 2 kg dumbbells for upper limb exercises. You can use elasticated bands for resistance. And balancing exercises is very important for seniors. So, for example, to sit upright in a stool, maintaining proper posture, to support themselves against a table and then do stand on one leg so that they don't fall. Things like that, the simple things which can be done at home. Stretching for all the parts of the body is very important, because again, as there is Wolff's law, there is also Starling's law, that basically a stretched muscle will work at 120% of its efficiency. So even if you're doing strength training, you do your stretches first and then you do your strength training, your muscle will work at 120% of its original efficiency if it's well stretched. That's a physiological law. So I think this applies at all ages, including for the seniors or anybody for that matter. So it should incorporate the basic elements, all these: cardiovascular fitness, strength, flexibility, and balance.
Now, coming to the nutritional aspect, what do you think of collagen? Is it just a fad, or do the supplements actually have a preventive role?
Supplements have to be viewed with caution, because there's no doubt that they are extremely useful, but it's also a great marketing opportunity for people to push products. And unfortunately, or fortunately, depends on your point of view, people do fall into these situations. Now, in my practice, I found that among the various supplements that work for joints, the type 2 collagen is the most effective supplement for the cartilage health that we have available right now. There's a whole basket of things available, but undenatured type 2 collagen is the one that I've seen the best results with. There are certain caveats that it'll work as long as there is no mechanical derangement of the joint. That is, there should not be any alignment issues and so on and so forth. There should be reasonable early stages of arthritis or normal joints. Great. Type 1 collagen, which is a slightly different type of collagen, works better for the tendons. So, for example, if you've got some issues with wrist tendon or shoulder tendons and so on, then we recommend type 1 collagen. Protein supplements, creatinine, of course, is very popular. The only word of caution is that while using these supplements, sometimes it is used in excessive cases, in excessive overload, and that can lead to kidney function problems. I recently had a very young tennis player who has been taking supplements on the advice of his coach, sincere advice, but probably not well researched advice, who actually landed up with acute kidney injury, actually hospitalized with acute kidney injury because of overdose of creatinine supplements.
How old
And
was he?
18,
Wow.
yeah, young tennis player, young tennis player. He's come out of that. Fortunately, acute kidney injuries do well, but it was a probably a big price to pay for, learning a simple preventive thing.
You brought in sports here and you've treated elite athletes and weekend warriors alike. What are some of the most common sports injuries that you see today?
I think, with while there is a growing population of IT professionals who don't exercise, we also have a lot of people who in Bangalore who are pretty much devoted to their exercising, and glad to say that we probably lead the country in terms of the running population, in terms of the cycling population. So a lot of people in Bangalore, do running. And especially people, the running population is mainly between 45 to 65, not 25 to 35. So you really have a huge number of runners, you have a huge number of college people who play football is very, very popular in spite of the vast dominance of cricket. And you also have a number of these sports arenas coming up where the IT professionals can go in the late evening and play five-a-side football and so on and so forth. So because I'm into sports practice, I probably see a lot more of these than others do. So essentially, we get a lot of overuse injuries as
Yeah,
well as a lot of acute injuries.
like
So the
ACL tears and
of course, the ACL tears, we'll be doing about 4 or 5 surgeries every week for ACL tears with or without meniscus injuries. These are typically because of, genuine injuries which can happen to everybody. And it can also be equally because of lack of preparedness, jumping off, getting off from the laptop and going straight away into the football field without adequate warm up, you know, not proper attention to equipment, gear, surfaces, all this kind of stuff. So that is one thing. And there's a significant amount of overuse injuries because of overtraining, because of ill-advised training. Now, a lot of the gym injuries that I see are typically people in the 40s and 50s who are doing, say, for example, Zumba classes. Now they are group classes with range of age ranging from 21 to 45, and the trainer is doing the same class for everybody. Now the 21-year-old is doing great, and the 45-year-old is feeling embarrassed not to keep pace with the 21-year-old. So she's putting herself beyond her limits,
Yeah.
and she may be 10 kg overweight and not done anything, and then they'll unmask degenerative in processes, cause injuries. So I think that just reinforces the point that you got to know your the age band you belong to and build up towards that. So this is one disadvantage of group classes where the trainer doesn't individualize the program. It's like teaching a class where the most brilliant student is sitting along with the person who's a slow learner, and you keep it at the same level, or it doesn't work that way. You've got to individualize it. So that's something we see a lot of. Again, in running programs, people who build up to 10K and half marathon too early, they get a lot of stress related injuries. And unfortunately, the recovery time from that is really long. It can take a year, 18 months before they can get back to running again. So that's something which is easily preventable by sensible training program.
I just want to go back to the athletes. Most athletes do get injured at some point in their career. But what really separates athletes who recover well from injury from those who really struggle to recover?
I think it's a whole lot of things which goes into injury prevention.
Like balance training? Is it impact training? Is it the prehab? I mean, what exactly goes wrong for these athletes?
All of the above. I think, see, a good training program would start with pre-season conditioning. It'll start with all your stretches and your gradual strength building, sport specific training, getting into it with adequate amount of preparation, knowing the climatic conditions that you're dealing with, knowing the surfaces that you're going to play on, and the huge aspect of nutrition. So what about adequate amount of electrolytes? What about adequate amount of water intake to prevent lactic acid buildup, to prevent electrolyte loss, to know your body under the test conditions? All these things matter. What about the balancing out the carbohydrate and protein in our diet? For example, most of the Indian diet is carb heavy diet, and lot of our calories. See, eventually the calories will come from the glucose, but carb heavy diets will have its own issues
Yes.
about spiking blood sugar, about deposition in the liver, fatty liver, so common in India. So it's a whole gamut of things. So I think one of the things that we should also emphasize is a little more of protein intake in a diet, not a crazy amount like which will cause kidney kind of issues, but adequate amount of protein in the diet is very, very important. So it's all these things put together which a good athlete will train for. The other thing is that adequate recovery time in between, participation in one event and another event. So there should be adequate recovery time to the body, cool down stretches, whole lot of things which are involved in that.
Do you
Whereas the
have
tip, yeah, sorry.
do you have an interesting case where recovery from a serious sports injury even surprised you?
Yes, I think that is the most famous example, of course, is Novak Djokovic recovery, which is, within a few weeks of meniscal injury, he came back and uh, won Wimbledon tournament, which was remarkable. But in my own experience, I've had, in the interest of the person's confidentiality, I won't name the person, but we had one of our weightlifters who won a gold at the Asian and then the bronze at the Olympics as well, who recovered from a back injury within 6 weeks enough. So she was completely laid up in bed 6 weeks back, and then 6 weeks later she came back with the Asian gold medal, which was a remarkable recovery within a short period of time. Which I think we all put in a lot of effort, her trainers and then the sports doctors like myself and nutritionists, psychologists, the whole. Of course, she was an elite athlete and she did very well to come back within a very short period of time.
Yeah, 6 weeks is really short.
6 weeks is really short. So that was a standout example in my career. But there have been many people who do it. So those, of course, I mean, are exceptions. But by and large, we should give ourselves, respect your body and give ourselves enough time, I think, especially for the people who are not pro athletes, who are not dependent on sports for their livelihood.
Right. So, coming to the Indian reality, research shows South Asians, Indians included, have lower bone density.
Yes.
Why is that, and what does it mean for us?
So interestingly, bone density in the black community is the best. Caucasian risk and Indian risk is almost equal. So Caucasians, white Caucasians and Indians are equally at risk for osteoporosis. And with India's young population, who is now 30, for the highest number of 30 to 40-year-olds in the world, or 20 to 40-year-olds in the world, by 2050, when these same people will become 40 to 60 or 50 to 70, we'll be by far the osteoporosis capital of the world by a long shot.
Why are we seeing so many osteoporosis patients, and why are we seeing so many hip and knee replacements in India today? Is it more disease driven or better diagnosis, or is it overtreatment? What exactly is driving this?
Yeah. So if you separate the two, I mean, if you look at the osteoporosis thing, it is largely the current population who is in the osteoporotic age group, that is like say 45 to 75 age group, or 50 to 80 age group. Most of them is because of lack of awareness. So they never knew when they were 20 years old that they should be doing preventive treatment. They've never really given adequate importance to balance, flexibility, strength training, like the way we've been talking about. They've been assuming that just doing my household work and daily chores, I'm busy, so therefore I'm exercising. You have to say work is not equal to exercise. Doing household work is not equal to exercise. So this is clearly the situation that we are in because of all these factors, like you pointed out, the reluctance for strength training in women, and on top of that, a huge racial preponderance. So racially, Indian population is predisposed to osteoporosis, just like Caucasians. So our brown skin does not absorb vitamin D as well as the Caucasians. The Caucasians have this advantage that the white skin absorbs vitamin D much more efficiently than us. So even though we have more sunlight in our part of the world, we still have vitamin deficiency because of poor absorption and lifestyle. So that's what it is. Now, when it comes to why more and more people are having hip and knee replacements, particularly knee replacements, see, the Indian phenotype is such that our knees, generally speaking, the bow leggedness is very, very common among us as a race, and especially so in Indian females, and especially so in Indian females who are between about 5'1" to 5'4", which is the average Indian female height. So a lot of them have this inherent bow-leggedness and then lifestyle. So by the time we get 50s and 60s, several of them have osteoarthritis. So the incidence of people needing knee replacements is only going to increase because still only a small percentage of those who need it are getting it done for several reasons. Reluctance for surgery, reluctance for, cost factor, all these factors. So although the absolute numbers are increasing exponentially, it is only a small fraction of those people who actually need it,
Okay.
because osteoarthritis is among the most common non-communicable disease in the world.
Right.
It's in number 4 position. So after your heart disease and diabetes and all that, osteoarthritis comes very high up in the list.
And we are more susceptible.
We are more susceptible. And the tragic part is that we are seeing this in 40s and 50s. So we are seeing people, I tell people that, see, your face looks like 45, but your knees look like 65. It's very unfortunate that the arthritis is we see in the middle-aged population is huge.
So, and that's largely driven by lifestyle and certain amount of genetic factors.
Correct. Absolutely. Lifestyle and genetic factors. And very often, many of these people are overweight. So I think that This is especially in Indian females, typically who were like 53 kgs in their 20s. After two children, they are at 70 kg, and then after menopause, they are at 80 kg, 75 kg. It's very common. And I think, they were not essentially uh, predisposed to become obese. So there you've got a situation where they are 55 and the body mass index is 37, 38, and very difficult at that point in time, because they are postmenopausal. And so then it's an uphill task to lose weight at
Right.
that stage.
So what I'm hearing you say is, look, the joint replacements, the surgeries that we keep hearing about, they're not really being overdone. In fact, they're being underdone. And you need to balance out the medical need with the patient demand. And some of it is more the media and so on, talking a lot more about hospitals and clinics oversubscribing or
No, I mean,
overprescribing medications. And
see, there is no doubt that there is a commercial angle to medical treatment, which is unfortunately the case. I mean, I have no uh, hesitation in admitting that. But certainly these things are highlighted that, oh, doctors are doing this only to make money, hospitals are doing this only to make money. It is not actually that, no, I don't know any doctor who would do a knee replacement in a person who does not need it, or the patient being so naive as to submit themselves for a surgery, for a major surgery without actually needing it. I think, that would be a very small, negligible percentage of people. So that's something which I don't think has much truth in it.
HRT, what do you think of HRT? And do you think it's underrated?
HRT is definitely was the treatment for osteoporosis before other things were available. And, the simple logic was that estrogen levels are going down at menopause. So supplement estrogen and, you can prevent the risk of osteoporosis. True. But then that has to be balanced against the other effects of estrogen, breast cancer, uterine cancer, ovarian cancer, all of these things.
But
So
hasn't that whole thing been busted quite a bit now?
it has been, but cancer word has such a scare that doctors themselves are reluctant to prescribe HRT. Gynecologists are very often reluctant because if they are not confident that the patient is going to come for regular follow-ups while on HRT for regular monitoring, then they don't want to take the risk. Like they've prescribed HRT and they next see the female 5 years later with a estrogen dependent breast cancer, then they'll feel, that could have been prevented if in case they had regular checkups and things like that. So HRT is a good treatment, but it needs monitoring. And I think that in general, the whole world population, including Indian population, doesn't do much for preventive checkups. So why osteoporosis is not treated? Because osteoporosis doesn't cause symptoms until there's a fracture. So there's no pain, there's nothing. Why do I need to get a bone density done? It's like that. So it's an asymptomatic condition till a fracture occurs. So similarly with HRT, person is taking HRT, they're leading normal life, they may forget to go for follow up and then they land up with a problem. So HRT is underutilized. And I think the reasons are because of reluctance of doctors to prescribe it, because of lack of confidence of follow up, and the cancer scare in women. No doubt what you're saying is true that it is a bit overhyped, but when you utter the word of cancer, then people are justifiably.
I've been having a lot of discussions with various physicians on this aspect of they keep referring to this research report, which has been debunked multiple times across clinical practices. But yeah, that's a whole separate discussion. Coming back to, what do you make of regenerative orthopedics and especially with stem cells, biologics and PRP, etc.? What are your thoughts on that?
So regenerative medicine, with the unraveling of the DNA chain and replication and ability to create tissue, it's been a great boon into medicine in general. And no doubt about it, you can regenerate heart tissue, you can regenerate liver tissue, you can regenerate all of this kind of stuff from the mother cell, which is a stem cell. But the last frontier in regenerative medicine is cartilage. So cartilage regeneration remains as the kind of, mecca where if someone reaches cartilage regeneration, then that would be the ultimate victory for regenerative medicine. So far, we are in the process. It's very much work in progress. There is a lack of standardization of protocols for stem cell therapy. There is no unanimity worldwide. There is a lot of haziness regarding the indications, where to use, what to use. There's a lot of subjectivity. There's a lot of commercial angle. There's a lot of hype.
Right.
So I think you should be approach it with caution. And a lot of people look at regenerative medicine as an alternative to joint replacement, for example. They'll say, my mother has got severe arthritis, but doctor, she doesn't want a knee replacement. What about stem cell therapy? Will it help? And that is exactly the situation where it will not help. Because, mom has already come to the stage where she's got severe arthritis. There is a deformity. The bone is touching bone. There is difficulty in walking. There's no soft tissue support. Muscles are giving way. No stem cell injection is going to support you at that stage. The same person 20 years back, yes, supposing a very early stage of arthritis, little bit of cartilage wear and tear, the joint is basically well aligned, meniscus is normal or slightly degenerated, ACL is normal. You give regenerative therapy, then it can help to preserve that cartilage. Even so, it is not standardized. So we have to remember that it's work in progress, and it's basically building on people's hopes. And unfortunately, a lot of hype happens because you ignite hope in a person. Oh, you take this injection and you'll be fine. And I think that that is not completely ethical. It's very, very important for the person receiving regenerative therapy to know, okay, these are the limitations. I can tell you this will not harm a person. It is not harmful. But the promises given by a lot of people, including people in the medical profession, saying that, I'll do this, that, and the other, you have to view it with caution. I do use regenerative therapy quite a bit in my practice, but I'm very selective about where to use it. So, as I said, early arthritis. Now, some places it works superbly well. For example, people who have, there is a tendo Achilles, which gets attached to the heel bone. Now, in that case, if we give a steroid injection into that, it'll tear the tendon, it'll rupture. But you give the platelet rich plasma, regenerative thing into that, it works very well in a number of cases. Now, this is anecdotal for me, but I've seen it work in 80% of my people. And if I've seen it work in 100 patients in my practice, then I would believe in it and I would advocate it. So it's like that, so, but this is still a personal experience of Dr. Hemant Kalyan and unpublished, but from my own experience. Similar, other doctors will have other such experiences. So it is work in progress, but it has promise. I definitely believe that we'll get there maybe in few years. The rate of change is very rapid nowadays. So we may get there earlier than we know.
Right. So what you're saying is, look, these therapies can work, especially more from an early intervention
Yes.
stage versus trying to adapt this at a later stage. And the fact that this science is evolving, it's fairly new, and therefore one needs to approach it with caution.
Absolutely. Absolutely.
Okay.
Absolutely.
Now, aging, we all age.
Sure.
And of course, your bone and muscle health is critical to aging well. But tell us a little bit about, how does bone and muscle health tie directly into independence and quality of life in later decades?
Oh, it's absolutely vital. Absolutely vital. Now, to illustrate this point, I'll take the example of a fracture neck femur. So, fracture of the hip area is one of the commonest fractures in the geriatric population. And you will be surprised to know that the people who survive 1 year after fracture neck femur is equal to the people who survive 1 year after cancer of the pancreas, which is one of the deadliest cancers. So the mortality is the exactly, so the number of people who will die within 1 year of a hip fracture in an elderly population is huge. Now, it's not the fracture that kills the person. It is the whole ecosystem around the fracture. The lack of mobility will lead to poor muscle health, like cardiovascular health, renal problems, bed sores, psychological issues, and depression. And that immobility in the elderly person is actually like a death sentence. Because for elderly, now you take a person who's 20 years old and you can keep him or her in bed for 3 months and they'll bounce back. You do that at the age of 80 and that's it. The person will never ever walk again or will walk with great difficulty. Restoration of mobility in elderly is very important after fractures, and similarly, preventive. So to keep up mobility in the elderly is crucial. And for that, I think the highly neglected thing is the prevention of sarcopenia is hugely neglected. So sarcopenia, just like osteopenia is the deficiency in the bone strength, sarcopenia is a deficiency in the muscle strength, to put it very simply. And why people don't, they typically, as we mentioned earlier, the elderly, the fit elderly may walk, but very few of them will actually do some exercises using light weights, and very few of them will actually do low intensity, high repetition strength training exercises. Balance training is definitely neglected in these people. They'll overuse braces and supports, all these factors put together, and also social conditioning. The children telling their parents, don't do this, don't do that. So, all of these things together, unfortunately, will really, put you down in terms of your muscle health and bone health as you get elder. I think we should really be at the forefront of a movement to, educate the elderly. Now, elderly take a lot of, they subscribe to all this social media stuff. So it can be a very valuable tool for educating them on a persistent basis that, do some simple exercises to build up your upper limb strength using household tasks, because these days everything is push buttons. You push button for everything. So you don't do any, like, you would not do idli grinding anymore, you would not roll a chapati anymore. All sorts of stuff is now
Very much.
mechanized. Yeah. So I think with the advent of all the touch technology, you need to make extra effort to use your upper limbs in particular and the spinal and core muscles. So, abdominal exercises, very important for elderly. Yoga is a great thing for balance, which we haven't spoken about, but I think that's the adopted the world over as a fantastic balance and coordination. Yoga is easily the number one balance and coordination which anybody can do.
Now, looking forward, what excites you most? What's coming in orthopedics for the next decade or so? For
Oh yeah,
example, like in terms of robotics and 3D printed materials and custom implants. What are you
absolutely.
really looking forward to?
I think you hit upon all these aspects. So, as you know, the start of my practice, I was among the people who started arthroscopic surgery in Bangalore in a major way. 30 years on, it was very interesting that I had to, become a student again and learn robotic knee replacements and hip replacements, just like people 20 years younger to me were doing. And because it is a new technology and as an ever evolving field, and it's been such an exciting journey that things that I've been doing routinely for 30 years of my practice. Now I've adopted robotic technology in such a major way that today 60% of my knee replacements, or more even, 60 to 65% are robotic. And it's not for any other reason, because I've seen the results of well selected cases using technology. So I think technology is part of every aspect of our life, and medicine is absolutely no exception. And we should have, as doctors, an open mind to adopt technology for the benefit of our patients. There's no question that it is an integral part of our thing. I think that AI is also going to come in, and while it is going to have its downsides and people will make a lot of self diagnosis, it will also help a doctor. Say, for example, if you have a pathology specimen, which is a very rare condition, I'm sure an AI enabled technology will recognize a pattern which pathologists may see very rarely. For example, it will help in diagnosis of MRI and radiological applications. And in our field, robotics is only increasing. So now we can do revision surgeries. It's coming in revision surgeries using robotics and 3D printing, which you
What,
mentioned.
what's a revision surgery?
Yeah. So revision surgery is when we've had someone has had a knee replacement, say done 15 years ago. Recently, I did a neurosurgeon's mom. She had her first knee replacement here in Bangalore by a senior surgeon back in 2003. Now it is 2003, 2008. I beg your pardon. So it's been number of years later, 15, 17 years later. Now we have to do it again because it's become loose. It's a mechanical part. Now, as of today's technology in India, we don't have robotic aids for this kind of situation. We have to do it manually, and we do it well, no doubt about it. But good can only get better. So we'll have robotic technologies for doing redo surgeries, like revision surgeries. which will be great. And then 3D printing and customized implants. So 3D printing we right now use for hips, and Bangalore is leading in 3D printing technology. So at very low cost, for within 3 days, we can get a 3D printed model of the pelvis, and we'll get a implant which can be created with a template. And then you'll say, okay, you put the screws in here and put the hip in here, and and we would also have customized implants. Now, for example, you're buying a ready-made T-shirt, small, medium, large, extra large, versus tailoring a shirt at 35.5 inches versus 35.75 versus 30.36 inches. So the fine tuning, you know, the implants available in the market are based on certain parameters. Now, someone has got a wider femur and not higher femur. Someone has got a narrower femur but a taller femur. These variations cannot be accounted by the current sizing mechanism. So, if you have customized implants, it'll be great. I mean, 2 weeks earlier, we'll say, yes, this is the CT scan implant for this person, and do it. 3D printed implant. So, it's an exciting journey ahead.
I just wanted to go back a little bit in terms of we spoke about surgeries. What would be your recommendation to most people who are planning? Because most of these surgeries are planned surgeries. So, what would you suggest they do so that A, their recovery is better, and B, they're stronger at the end of it?
I think one of the aspects which is neglected by surgeons is the prehabilitation, because very often the surgeons at a certain point in their career may become more interested in the technical aspect of surgery rather than being doctors. So no surgeon should forget that primarily they are doctors and they are also surgeons in the process. So the process of prehabilitation starts at the time of the first consultation. So if I'm advising a knee replacement surgery, I'm never in a hurry to give a date tomorrow or day after. So unless the patient has some really pressing emergency to do it tomorrow or day after, ideally planned, you do prehabilitation and simple. For example, if you're doing a knee replacement and you do good quadricep strengthening exercises, familiarize the person with the routine that they're going to follow post-operatively. We have seen, and it's been documented by literature papers, that those patients do far better post-operatively in terms of recovery. If a person has a hip replacement, they strengthen the hip abductor muscles and the spinal stabilizers before surgery. They walk faster and better after surgery.
Right.
So I remember one of our neighbors on whom I had done a hip replacement surgery. We had given her some time. She did prehabilitation. And then just 6 months after the hip replacement surgery, she happened to travel with me to Spain and climbed up a tower which is equal to 51 floors.
Wow.
51 floors on a ramp in a Spanish town. She climbed 51 floors, toe to toe to me, with me, and she was just about 5 meters behind me when we reached the top. So that was all because of the time she spent in rehabilitation. And, that helped the recovery so well.
What would be the 3 habits which you would recommend to listeners start today for longer musculoskeletal health span?
So the number one is exercise. There is no question about it. I think that we'll go back to what was said, that if you are below 100 and if you're alive, you should be exercising. So that is point number one. Point number two is the lifestyle. So, it's very easy to fall into, to make excuses for yourself. Oh, I am busy. Oh, I am that. So just a active lifestyle, like walk instead of taking the elevator, park the car 300 meters away and walk to your destination. Simple day to day things. Get up to answer the doorbell. So just generally be physically, one is formal exercise, second is physically be more active. And the third point is the nutritional aspect, with special emphasis on vitamin D, vitamin B12 for vegetarians, and adequate protein in our diet with a little bit less of carb loading. I think if we follow this as three simple general guidelines which can be applied to almost anybody, we'd be a healthier population tomorrow.
Great. So that's a perfect note to end our deep dive. And before we wrap, we have a tradition here on Brighter 100
Okay.
where we ask a few quick fire questions to our guests. And I would like to ask you a few to get to know you beyond the clinic.
Okay.
So, are you ready?
Okay.
So, if you could put one message about bone and muscle health on every billboard in India, what would it be?
You'll have to think this one through. If you're below the age of 100 and you're alive, you should be exercising.
Great. What's one personal health habit you never compromise on?
I think that my adherence to regular, moderate exercise and diet I've maintained since the age of 18, and now my body weight has been the same since the last 25 years, which I'm proud of.
If you could have dinner with any figure, anybody in the world, past, present, any figure in the history of orthopedics, who would it be and why?
In the history of orthopedics,
That's right.
okay, then that would be clearly Sir John Chanley, who developed the modern day hip replacement in his garage and using simple tools. And he has the most enduring design of hip replacements that has lasted some people with 50 years on. And I have personally had patients 25, 30 years on hip replacement, which I put in the 90s and they're still going strong. So I think in terms of the enduring design, and the concept, it has to be Sir John Chanley, who is the father of modern day hip replacement in the orthopedic world.
Dr. Kalyan, I know we've overrun time, but thank you for sharing your wisdom and stories with us today.
It's been a pleasure, Anil, and all the best to the listeners of your program. And let's hope we all get to be a healthier 100 if we get there. If not, at least till whatever age we get there, let us get there healthy.
Yes. This conversation reminded us that strong bones and muscles aren't just about preventing injuries. They're more about living fully, moving freely, and staying independent as long as we can. To our listeners, stay young, stay healthy, and stay fit. Thank you.